I'm describing a robotic Whipple pancreatic duodenectomy done with the SSI Mantra robotic system. We performed this procedure with the 4 robotic arms. The camera was placed below and to the left of umbilicus. The right side, the R1 port was about 8 centimeters away from the camera. The R2 was on the right side of the umbilicus, which was 8 millimeters, and R3 was furthermore in the right flank, which was also an 8 millimeter. 2 other additional assistant 5 mm ports were used, and 1 assistant 12 mm port was used for stapling. Initially, the first part was done laparoscopically, where the DJ flexure was being identified. The DJ flexure mobilization was done, which was an infracolic step. Next, the hepatic flexure was mobilized and the duodenum was second part was seen. Mobilization of the hepatic flexure of the colon was continued towards the liver, the right upper quadrant of the abdomen. The duodenal cauterization was done partially. The second part of the duodenum was mobilized from its retroperitoneal attachments. The falciform ligament was hitched, and the gallbladder fundus was also hitched to the parietes to get a good exposure of the hepatic hilum. Once these steps were over, the robot was docked, and now with the robotic instruments, the gastrocolic omentum was being divided, and the lesser sac was being entered. The dissection was then continued further towards the antrum of the stomach. The station 2 and 4 lymph nodes were taken. The posterior exposure of the pancreas was achieved between the stomach and the pancreas by lysing the adhesions. The right gastroeploic artery and the right gastroeploic vein were identified, dissected, clipped, and divided. Next, the posterior mobilization between the pylorus, the duodenum, and the pancreas was continued. The right gastric artery was taken here, and a window was created to transact the first part of the duodenum. Next, the cholecystectomy was performed. After all the steps, the cystic duct was taken with clips and divided. The hepatic duct, the common hepatic duct above the insertion of the cystic duct was dissected at its proposed site of future division. The gastrointestinal artery is being identified. At the lower border of the pancreas, which is dissected here, clipped and divided. The inferior border of the pancreas was then exposed to identify the supramesenteric vein, and it was dissected away from the pancreas. A tunnel was creating between the supramesenteric vein and the pancreas, and an umbilical tape was being applied here. The third part of the duodenum, the fourth part of the duodenum were dissected. The DJ flexure was mobilized, and the duodenum and then the proximal jejunum were then taken up into the supracolic compartment by mobilizing the DJ flexure. The jejunum was then divided at its proposed site of division, and then the pancreas was divided at the body of the pancreas by lifting the umbilical tape to protect against the portal vein. The pancreatic duct was identified and an infant feeding tube was placed. The Uncinate process dissection was then started with the use of bipolar and a combination of harmonic. By using bipolar and harmonic close to the supramesenteric vein and the supramesenteric artery. The assistant suction would do the suction part and the retraction of the supramesenteric vein. Finally, the common hepatic duct is being divided. Above the cystic duct junction, the 3 stents are being removed, and the final specimen removal is being done by dividing the posterior wall of the common hepatic duct, and the pericholedochal tissues are divided along with the lymph nodes. The specimen is now placed in an endobag to prepare for reconstruction, and the endobag is now placed in the left upper abdomen. The first reconstruction that we do is the hepaticojejunostomy. We prefer here to do a continuous anastomosis in view of the dilated hepatic duct. The posterior layer is being started, and then the anterior layer is being performed here with the 3-0 PDS in a continuous fashion. The next anastomosis is the pancreaticojejunostomy, which is done as a 2-layer ductal mucosa. The posterior layer is by a 3-0 ethibond interrupted sutures. By taking the pancreatic parenchyma with the jejunal serosa, seromuscular sutures, multiple interrupted sutures are taken to abut the pancreas with the jejunum. The jejunum is being opened here, and then a ductal mucosa anastomosis is constructed by using 4-0 PDS. In the robotic technique, the main advantage is that we get very good angles for suturing with precise suturing possible. The next step is to do the anterior layer of the ductal mucosa anastomosis after placing the stent, internal stent into the jejunum. And finally, the 4th layer or the anterior layer is started, interrupted 3-0 ethibond to bury the pancreaticoductal mucosal anastomosis. Finally, gastrojejunostomy stapled is being done here. The stomach and the jejunum are being opened after a stay suture, and endo-GI A45 is fired to create a anastomosis, and then the enterotomy is closed with a running 3-0 PDS sutures. At the end of all the anastomosis, completion cholecystectomy is done, feeding jejunostomy is created, and 2 drains are placed into the pancreatic and the hepaticojejunostomy bed, and final closure is achieved after specimen extraction. Thank you very much.